Buenas tardes a todos e a todas. Sou Silvia Cassiani, sou assessora de enfermeria e técnicos de saúde da Organização Pan-Americana de Salud e estamos em Washington, D.C., Estados Unidos. É gusto para nós outros ter a todos ustedes nesse evento que estamos programando como parte de los trabalhos que realiza a Unidade de Recursos Humanos para a Salud do Departamento de Sistemas e Serviços de Saúde da OPS. Hoje estaremos com a doutora Paula Neira. A doutora Paula Neira foi membro da Academia Naval de los Estados Unidos em 1985 e se graduou com distinção em la Academia Naval de los Estados Unidos. Também é certificada em enfermeria de emergência e centrou sua carreira em la atenção de adultos em reanimação e trauma de emergência. Também é copresidenta do Grupo de Trabalho Executivo de Medicina Transgênero desde novembro de 2016 ao 2022 e se convertiu em diretora fundadora do programa clínico do Centro John Hopkins para a Saúde de Transgênero. E em março de 2022 foi nombrada diretora do Programa de Medicina de John Hopkins de Equidade e Educação e da Oficina de Diversidade, Inclusão e Equidade em Saúde. Como vocês podem ver, há largo currículo de expertise da doutora Paula Neira, incluso é advogada e membro do Colégio de Advogados de Maryland desde 2011. E, además, há que dizer que foi a primeira graduada da Academia de Serviço de los Estados Unidos em lograr como enfermeira estadunidense. É gusto para nós, doutora Paula, desde a OPS, estar contigo na tarde de hoje e escuchar suas experiências sobre a identidade de género e orientação sexual e como enfermeros têm e enfermeras têm o rol nesse trabalho. Muitas graças. Adelante, por favor.
Thank you, Dr. Cassiani, and thank you so much to everybody for the opportunity to be with you tonight, for Bruna and Maria for extending the invitation. I'm really looking forward to interacting with the group. We can go to the next slide. So that's me, and part of what I do is I'm the sponsor of one of our newest ships that was named after Harvey Milk, who was an American civil rights leader for LGBTQ people. And I got to break the champagne bottle when we named the ship last November. I want to express a thanks to our interpreters tonight. Is like many second-generation Americans, I have lost most of my ability to speak the language of my grandparents. On my father's side, my grandparents are from A Coruña in Galicia in northwestern Spain. But unfortunately, I speak really bad New York English more so than I can in Spanish. So I want to thank them for being here with us tonight to facilitate our conversation. And I really want this to be a conversation as much as we can. I know we're doing this via the remote platform, but I want you to feel that this is a safe space. And when we get to the question and answer period, please don't worry about asking a question that you may think you're not saying it right or you're not using the right words. Is because this is a time to ask questions, and without worrying about, because you're certainly not going to offend me. And I always joke that, as I mentioned, I was an emergency room nurse and I'm a lawyer and I was in the military. So I'm as crusty as they come. And as a lawyer, I don't have a soul, so you don't have to worry about offending me. Next slide. Now, as a lawyer, there's, the standard disclaimers is I don't own the copyrights for any pictures. And this may be an American thing that we worry about, that kind of stuff, but is I don't own the copyright for the pictures. And we're going to be talking about some concepts that nurses have to understand about caring for transgender folks. And that means brushing up against issues like religiosity and politics, because whether we're talking about the United States or whether we're talking about Central or South America, those are aspects of the culture that frame how we give care. And if you don't like what I say, because depending on how you identify, you may agree or not agree. You can't blame Johns Hopkins Medicine. You can't blame the United States Navy. You can only blame me. You can say, Paula was really dumb. Yeah, I don't agree with that. But so you blame me, not them. Next slide. So the things that we're going to talk about tonight is going to go over some basic terminology about sexual orientation and gender identity and the various communities that make up the LGBTQ community, and do my best to translate this, because depending on your country, the local culture, some of that language may not translate directly. Also, and I'm very aware that my experience in the presentation and unfortunately still a lot of the research and a lot of the information about caring for transgender people comes from the global north. Most of the literature comes from either North America or Western Europe. Most of the literature is in English, and certainly want to understand that there is a lot to be learned by sharing globally information. I'm going to talk about some of those challenges and opportunities and looking at cis heteronormativism. And I'll explain what that is. And it really is a facet of, many, many cultures that were influenced by Western European colonization. Because as I'll mention, many indigenous peoples around the globe viewed gender beyond just the binary and very strict interpretation that was characteristic of that Western European view. And that view has shaped some of the unconscious bias that we come to the healthcare with. I'm going to talk about some of the health inequities and the negative impacts of social determinants of health. Because when we think about health, it's not just the absence of disease or illness. It really is looking at, excuse me, at all of those factors that influence how people are able to live their healthiest life. I'm going to talk about some very specific actions that nurses can do when you're interacting with patients and working in clinical settings, and all clinical settings, not just at the bedside in the hospital, but also out in the clinic, out in the community, wherever you're at. Things that you can do to increase the quality of care and to create a more welcoming, supportive, health promoting environment for our patients. Next slide, please. Now, the biggest takeaway from our talk tonight is really understanding that we are going to treat every single patient with dignity and respect. And some of the things that we're going to talk about tonight is how you do that for transgender and gender diverse people, not if you're going to do that. Don't be a jerk. We as nurses, besides our code of ethics, is, as human beings, we want to treat people the way that we would like to be treated, or we would want our loved ones to be treated if they were the patient. Don't make assumptions about people based on how they look or how they sound. I'm sure that if you couldn't see me and you didn't see my name, my first name being Paula, and you were just listening to my voice, the unconscious bias, the assumptions that we've been taught, you would think to use words like sir or mister in regards to me because my voice is deeper. I joke that I sound like a brassy old broad from New Jersey because I'm old, I'm brassy in real life, and I really am from Jersey City, New Jersey, which is in the northeast part of the United States by New York City. Give yourself some grace because you are going to make mistakes. It's not a matter of if you're going to misgender somebody or if you're going to use the wrong words. That is going to happen because you're human. When it happens, if someone corrects you, accept the correction with grace. Thank them for pointing it out to you. Make a genuine apology. Don't say, I'm sorry if you were offended, because what that really means is I didn't do anything wrong and you're too sensitive. You need to say, I'm sorry. I will pay more attention, and then pay more attention. Don't make the same mistake twice, because if you make the same mistake twice, what it really means is you weren't really listening. You weren't really paying attention. And don't make it about you. Don't say how hard it is for you to get somebody's pronoun right or to call somebody by the name that they have told you to use, because it really isn't. And if we think about it, we are able to shift pronouns or shift someone's name for many, many other reasons. And this is just another one of them. Next slide, please. Okay, so the first thing is let's talk about some basic terms. Next slide. Okay, here are some basic terms. Is gender identity is that deep-rooted sense of yourself in a gendered way. And most of us come from cultures and live in societies, across countries that have very, rigid binary views of gender, that you have male and female, and that's it. Well, that deep-rooted sense of yourself, which rests in your brain and really has nothing to do with your genitals, with your chromosomes, with your genes, or primary, secondary sexual characteristics. Because to remember that in utero, our brains form at a different point in time than the rest of our body. And I can't sit here and tell you exactly why people have different gender identities. Science has not found a definitive answer. But we do know that it rests in the individual. When we talk about things like gender expression or gender stereotypes, gender expression is how we express that sense of ourselves. And again, whether we're talking about masculine or feminine, that's often defined by our culture, what we consider masculine, what we consider feminine. The gender stereotypes are those roles and expectations that we put on people, again, based on gender. Now, sex assigned at birth is, for most of us, the designation of being male or female that was made when we were born. And very little science goes into that. When we're born, the clinician that delivered us is taking a quick look at external genitalia and is looking for a penis or a vagina and makes that assignment. And at least in English, sex and gender are not the same things. In English, we use it interchangeably. Gender is much more of a social construct and a broader concept than what we try to capture when we say sex. Now, Sexual orientation is who you're attracted to. And it's a separate component of who we are. Every one of us has a gender identity and a sexual orientation. And depending on how we identify as men, women, non-binary people, and as we're going along, I'll explain some more of the concepts. And how the person we're attracted to identifies is how we, what language we use to describe that. Most of us, I'm willing to say that most of us on the call tonight, or the term we would use is heterosexual or straight, which means if you identify as a woman, you're attracted to men. If you're a man, you're attracted to women within that binary. The term bisexual is, again, within that binary, means that as a woman, I may be attracted to men and women. A term pansexual, a newer term used by younger generations a little bit more, means that you're attracted to other human beings, and the person that you're attracted to, their gender isn't a salient point for you. You're attracted to the person. And people who are asexual are not attracted to other human beings in that romantic, physical, sexual way. For gender identity, most of us are cisgender. That word means that your gender identity is aligned with the sex you were assigned at birth. Transgender is, again, a broad term for people whose gender identity does not align with the sex they were assigned at birth. The term transsexual is used more often outside of the United States, and that may be a term that many of you are more familiar with. To try to mean the same thing, but it has a much more clinical meaning of individuals whose gender identity doesn't align with the sex they were assigned at birth and have sought some medical treatment, some gender-affirming medical treatment. Next slide, please. Now, to understand about how people identify in terms of gender identity, there are about 72 different ways that people may identify their gender identity. So we as nurses, one of the things to think about is, instead of trying to label people, is to ask people how they identify their gender identity and what terminologies they use, and then use that same terminology to allow the patient to define themselves, as opposed to us trying to apply a label. Next slide, please. Now, the acronyms that you see, like LGBTQ+, that is just one. There are several forms of that acronym, and it's really used to describe all of the different communities that are defined by sexual orientation or gender identity that are different than being cisgender and straight. Now, in technical writing and in the research, you may see an acronym of SGM, which is for sexual and gender minorities. It's a term that was created by the National Institutes of Health here in the United States. That's not a term that people in the community actually use to describe themselves. And also, you may see an acronym TGD, which stands for transgender and gender diverse people. Next slide. Okay. So as I was saying, for us as nurses, we want to listen to the language that the patient is using, and then we want to follow their lead. It's allow the adolescent to use their words to describe themselves, to describe their anatomy. Now, the one caveat that I will say is that unless you are also a member of the LGBTQ+ community, there is some language, some slang that people inside the community may use that doesn't give you, if you're not part of the community, license to use that language. And what words that may be is going to be culturally defined, so it may be different between countries and different between regions. Next slide. Okay. So the next thing we're going to talk about is, the challenges and opportunities that we have when we're looking at how our structures were designed with unconscious bias and the cis heteronormativism built into it, and that those of us who have grown up in these societies are often blind to it unless it directly impacted us or a loved one. So next slide. Okay, so what cis heteronormativism is, it's a pervasive system of beliefs and attitudes that every human being is heterosexual or straight, and that there's a binary system of sex and gender, and everyone is cisgender. And if you're not straight and you're not cisgender, it means that there's something abnormal with you, that you are less than, that you are not entitled to the same rights, the same respect as other people. And this has been part of our societies and cultures for hundreds of years. And as I said earlier, indigenous peoples around the world had a much more broader view of gender. And the Western Europeans brought a very rigid structure. And because that colonization had such a major impact, that now hundreds of years later, we think that this is just the norm. This is the way it's supposed to be. And that's what this pervasive belief is. And while I have a picture here of Dory from Finding Nemo, the idea of a fish is, we don't ask a fish to describe water, because the fish doesn't know of water. It just knows this is the world in which it lives. And that's the same thing that we encounter when we're trying to understand that this belief has shaped how we perceive our world. Next slide, please. Now, for those of you who may be Star Wars fans, I'm a big Star Wars fan. I love quoting Yoda, the wise master, that we have to unlearn much of the stuff that we have learned. Unconscious bias is something that is human. It's not good or bad, it just is. And it was, bred into the species as a defense mechanism, because our brains cannot process all of the information we get. And it's used as a filter to be able to survive. And the reality is that when we are talking about transgender and gender diverse people, the unconscious bias has been very negative. And unconscious bias is formed on, it's grounded in our society and how we identify our worldview. And our worldview is shaped by our training, our education, our experience. It's influenced by our families, by our faith groups, if we belong to a different faith group, the government. And today it's shaped by media and social media and the internet and movies and music. And all of that is designed, to teach us the lessons of how we navigate in the world. And these are those mental shortcuts. I am a woman who's transgender. When I was born, I was assigned male when I was born. By the time I was about 8 or 9, I knew something was different about me, but I didn't have any language to describe it. And I'm 59, so we're talking about the early 1970s. So we're talking a half a century ago. When I was 11, I had the conversation with my mom and said, "Mom, I think I'm a girl." And it wasn't because I liked the color pink or wearing dresses or playing with Barbie dolls. That might have been fun, but there was nothing effeminate about me. I was a football player, and when I say football, I'm talking globally. I played soccer. I'm a goalie. I played baseball. I collected baseball cards, and I played with toy soldiers. But that doesn't change how I felt inside. But when I said that to my mom's reaction was horrible. You know, she freaked out, as she recoiled. And in that moment, I learned that you do not want to be one of those people. And I didn't even know who those people were. But I knew that from my mother's reaction, what I said was wrong, that was shameful, that was not accepted. You know, don't have this conversation again with my mother. Don't say anything to my father. And, you know, culturally, my dad is a first generation American. Both of my parents have since passed away. But my dad grew up in a traditional Hispanic, Spanish, patriarchal family. That, you know, that's my family's background culturally. And so don't have this conversation with him. And it's those messages, you know, my mom didn't say that out loud, but that's the message young me learned. And that's the message that in many of our cultures is still being sent, that this is not something that's acceptable. Next slide, please. And I put some, on this slide, there are some examples of our forms, whether it's in electronic medical records or whether or not we're looking at paper forms. And that's going to, you know, vary depending on your clinical setting, the amount of resources that are available. But what the problem is the questions and the way that they're laid out. They're grounded in this assumption that everyone is straight and everyone is cisgender. We don't ask somebody if they have a chosen name, which may differ than their legal name. We don't have any salutation for someone who is non-binary. And a non-binary person, their gender identity isn't exclusively male or female. When we say, you know, words like sex, you only see male and female. There is no other option. And we know that human beings are way more complex. And here in the United States, more younger people are identifying in non-binary terms. The latest study shows that in the United States, about 1.2 million people identify as non-binary. So that's 1 million out of about 330 million people. But our systems haven't caught up to be inclusive. So again, one of the things as a nurse, to be an advocate for our patients and to create that environment where they feel welcome and trusting to share this information, because people are afraid to share that information because it then opens them up potentially for discrimination. You know, to make sure that our forms are inclusive and using language that welcomes people into our settings. Next slide. So when we look at, you know, the structure of how we provide healthcare, and again, this varies by country. Some countries have more resources than others. Some regions of the country have greater access to care than others. In the United States, insurance is an issue, is much more of an issue because of the way the American healthcare system is structured, as opposed to other countries that may have a national health system. When I say ownership and affiliation, again, one of the challenges in the United States that may or may not apply where you are practicing is many hospitals in the United States have religious affiliations. And if you're affiliated with a religious group that doesn't accept the existence of transgender people, or say that being transgender is immoral and won't provide the services, that's a barrier to care. You know, training and education. it is so great that so many people are here tonight and we're able to have this interaction, because very few of us have had any training on how to care for transgender people, what it means to be transgender in our formal schooling, whether it was in our basic nursing education or orientation or any kind of continuing education we get as our career progresses. When we look at our facilities, what does the sign say? One of the examples is like for lactation. If we say mother's room, we're not being inclusive of the fact that today non-binary people that were assigned female at birth, or a transgender man, and that means someone who was assigned female at birth and is a man, may bear a child and may lactate. So how we use words can tell whether or not someone might feel welcome and comforting in a setting. And it's a challenge because you want to make all of our patients feel welcome. Our forms just talked about that. And then within the electronic medical records is, do we have mechanisms where people can tell us a chosen name? Because that may differ than their legal name. And, again, in the United States, many transgender people have not been able to get a government issued identification document with their correct name, with their correct gender marker. And when they don't have that, that opens them up to harassment. Also, very few of our systems actually collect the demographic information about people's sexual orientation and gender identity. So when we're looking at programs and health equity issues, excuse me, if we don't even have the basic data to know the size of our population, we can't make those in-depth evaluations in ways that often we can do when we're looking at different impact in race or ethnicity or language. Next slide. Okay, so let's talk about some of those inequities that the community faces. So next slide, please. So, as the WHO in describing what health inequities are, they're avoidable inequities between groups of people within countries or between countries. And they arise because of different societal treatment of different groups of people. And it's beyond just medicine or nursing. It's all of those social and economic conditions and their effects. When we talk about social determinants of health, all of that goes into playing as to how healthy and how much health promoting behaviors people can engage in or not engage in because they don't have equal access to care. Next slide. So yeah, so social justice is a matter of life and death. It's, where we're born, how we live, how we grow, where we work, what kind of work we do, how long we live, what our life expectancy is. Government policy, cultural norms, societal values. Structural determinations, education, able to access school, what type of social position you have, how that society is structured, that it has preferred groups and marginalized groups. And that's broadly speaking, there is no country that I'm aware of where transgender and gender diverse people are not a marginalized community. And then, what the healthcare system looks like. I'm fortunate and I'm privileged that I live in a country supposedly with, world leading healthcare, yet we have major challenges and major barriers for the marginalized communities that live in the United States to be able to access healthcare in the same way that, those who come from higher socioeconomic strata who are white who are heterosexual, who are cisgender, can access than other populations. And it's the same across it. The structural problem is the same across the globe. How it plays out and what it looks like on the ground is going to vary by where we are on the globe. Next slide. Now, the United States government only started caring about transgender and LGBTQ health about a decade ago. And one of the things that the government, in starting to look at the health of the community, noted that the social determinants of health, those negative impacts, were largely grounded in oppression and discrimination. There wasn't anything inherent about being transgender that made people more susceptible to illness, more susceptible to not being able to live to the fullest of their potential. In the United States, where it's the legal discrimination, it is okay to discriminate against someone based on their gender identity or their sexual orientation. That was the law, that was basically the law of the land in the United States until very recently. So when our highest court said, no, you can't do that because it's a form of sex discrimination in employment. Now, whether or not that also applies in healthcare and in housing and in education is an ongoing debate in my country. But generally, there's a lack of law. Although there are some countries, Uruguay has been very good in being progressive with some laws and understanding that potentially reparations for those who have suffered injustice in the past is something to look at. That's much more enlightened than the United States is on the subject. Right now in my country, we're seeing a concerted attack being targeted against transgender youth, trying to bar their access to medically necessary care or bar them from competing in sports aligned with their gender identity. And the ability to play sports, to interact, has beyond just the physical health benefits of being active, the societal interactions, learning team building, learning discipline, learning how to interact with different people is lost. And we already know from the start that LGBTQ youth don't participate in athletics as much because they're afraid of getting discriminated against. And in the physical environment, not protecting people from bullies, not having access to recreation, not being able to access healthcare, let alone healthcare that is both culturally and clinically competent. Next slide, please. So how this plays out in health disparities and in health things, LGBTQ folks have a much higher risk of suicide. 40% of transgender adults have attempted suicide, based on the largest study ever done in the United States. Among transgender youth, the number that contemplate suicide can be as high as between 80 and 90% because of the lack of support from their families, from their churches, from school. Recent studies also show that if a transgender adolescent has one adult in their life that is supportive and affirming, the risk of suicide drops by half. The risk of violence. In the United States, a transgender person is 4 times more likely to be the target of violence than a non-transgender person. 2021 around the globe was the deadliest, most violent year for transgender people. The most violent country for transgender people is Brazil. And most of the transgender people that are targeted are Black and brown transgender women. There's an increased risk for HIV or STIs partially because the increased risk for substance abuse as a method of self-medication, trying to cope with the societal stigma and discrimination, increases risk for exposure to HIV. But then also is that many transgender people have to resort to survival sex work because they're so marginalized in their community, they can't get proper employment, and they still need to be able to, make money to be able to buy food, have some place to stay, and that just increases their risks. Mental health concerns, increased risk for anxiety and depression. Again, not because they're transgender, but because society treats transgender people so poorly. Again, probability of eating disorders, again, using food as comfort or having unrealistic body expectations based on societal definitions of what's masculine and what's feminine. We know because of a fear of discrimination, transgender folks participate less in cancer screening, higher risk for tobacco. Besides the fact that there's targeted advertising to the community, smoking is also, the use of nicotine is also another self-medication, another coping mechanism. And that, again, across the globe, we lack a lot of the basic data on sexual orientation and gender identity to be able to really look at our programs and see really how deep the disparate impact might be. Next slide. So why? And again, I go back to using Yoda, and it really is about fear. It's about playing to people's fear and their ignorance about transgender people, about what transgender healthcare is, that then leads to people to have beliefs and attitudes that then play into that stigma and discrimination. Next slide. So, in Central and South America, as opposed to, the United States, it's going to vary by country. There's progress in some places and regression in others. What is similar to the situation we see in the United States is that social and religious conservatives oppose treating LGBTQ people equally in society. And that opposition is grounded in religiosity. I already mentioned that Brazil is the most dangerous place, but then also countries are making progress. Argentina, Chile, Uruguay. I saw someone entered a comment in the chat about Ecuador, and I think it was, my Spanish isn't that good, but I think it was, an example of Ecuador taking a positive step forward. Next slide, please. And again, using the United States as an example, in my country, this year alone, and the way, the United States is structured, we have 50 individual states that make up the United States. Over 300 bills have been entered at the state level trying to roll back or restrict the rights of LGBTQ people. And almost half of them target transgender youth in the way that I just mentioned. And looking specifically at what that impact is on adolescents and youth here in the country, I said half in the last year have had suicidal ideation. 3 out of 4 of them have report being discriminated against. For transgender kids, less than 1 out of 3 live in a home that accepts them. I told you what my mom's reaction was a half a century ago, and my mom loved me. Eventually I had the conversation again with my parents. They never quite understood. My mom always thought that she had done something wrong until the day she died. My dad would get the pronouns wrong sometimes, but I knew that I was loved, and I knew that my parents wanted the best for me. But like you can see, very few kids, the minority, are in that situation. And 60% would want to access mental health care, but can't. Excuse me, next slide. Now, I mean, to drive this home here in the States, that tie between religiosity and politics, and in my country, it's because of the way the political structure is here in the United States, we only have two major political parties. Well, one of them, for partisan power reasons, has aligned with hate groups, and these hate groups describe themselves as Christian. And for full disclosure, I'm a Christian. I was raised as a Roman Catholic. I graduated from the #1 Catholic high school in the United States, and I was taught theology by the Jesuits. So I can talk about theology if we ever get together in real life, somebody can buy me a drink and we'll talk about it. But it's driven by using religion, and actually not religion, because there's nothing in Christianity that justifies this. It's religiosity. It's how individual people interpret their religious scripture that justifies discriminating against people because they're different. And this, the same themes apply across Central and South America. So next slide, please. Okay, so now, now the ultimate question is, what can I do about it? What can I, as the nurse trying to take care of people, what can I do? Next slide. The most basic thing is create a safe environment. Use somebody's name and pronouns. Use the right, use the right terminology, again, as defined by the language and the culture. Ask appropriate questions in an appropriate way. And look at your nonverbal communications. What's your body posture? When somebody says, when an adolescent, a 15-year-old says, I identify as non-binary, do you stand there and roll your eyes at them like, oh, come on, give me a break? That sends that very strong message about whether or not that's acceptable. And most of our interpersonal communication is nonverbal. So we've got to pay attention to that. Next slide. So now I mentioned, the right name and pronouns. And here's a new way to introduce yourself. And again, with the understanding that this is coming from a English-speaking perspective. So, depending on the language, depending on the situation, there, whether or not there are gender-neutral pronouns or, those terms may differ. But basically it's, hi, I'm Paula. I'm going to be your nurse. My pronouns are she and her. How would you like me to address you? And what pronouns do you use? And that gets rid of all of those assumptions that we make based on what people look like and they sound, or how they sound. You don't want to ask somebody, what's your real name? Because that's offensive. Now, one of the challenges in dealing with adolescents is you may be dealing with an adolescent who has not yet come out to their family because they're afraid that they may be kicked out, they may be the victim of violence, they may get disowned. Those are real fears. So you have to navigate maybe when and how you're going to use the name and the pronoun when you're interacting with the adolescent by themselves versus how you may need to address them when their parents are present so that you don't inadvertently out an adolescent to their parents that are not supportive. Because the thing that should always drive you is making sure that you try to keep the child safe. Now, for non-binary folks and talking about, coming up with pronouns to use for non-binary folks is, I've put on the slide, some pronouns that I was able to find by searching the internet. And I was happy to find that there are ones in Galician, but this is not yet mainstream. This is, we're on the cutting edge. We're on the change in language, and language always evolves. tonight you're talking to a very conservative, older white woman from the global north. A non-binary adolescent in Peru or Brazil or Ecuador may use much, much different language than I use. So again, listen, mirror, and if you don't understand, ask, hey, what does that mean? One of the things that I mentioned, and something to think through, and I do not have a bright answer other than always err on the side of safety for the child, is how do you deal with that situation where we want to be supportive of the child as they grow to understand themselves and want to live as who they are, when their parents or guardians are not supportive of that. Next slide. As I said, language is always evolving. The word transgender is an adjective. It's not a noun, it's not a verb. No one transgenders. Don't use language that's obsolete. On this, slide here, it shows you, don't say sex change. It's offensive and it's not scientifically accurate. It's outdated language. The words you're looking for, transition, that's that process of going from living aligned with your gender, sex assigned at birth to gender identity. Or gender affirming surgery, gender affirming treatment. And there is no such thing as a gay lifestyle, a transgender lifestyle, or sexual preference. We mean sexual orientation. But we're often, again, that unconscious bias. We've been taught to use words like lifestyle and preference to imply that your sexual orientation or gender identity is a choice. And it's not for anybody. And for the folks that are listening in, if you identify as straight and cisgender, tell me what day in your life, what day, month, and year you made a conscious decision to be straight as opposed to being gay, lesbian, bisexual, pansexual. I could be this, but I'm going to choose to be this. Or I chose to be cisgender, but I could be transgender. And the answer is you didn't. And neither did any gay or transgender person, using those as umbrella terms. What you see when you're interacting with adolescents that are coming out to you, that means sharing that information about themselves, is they're making a decision to live authentically as to who they are, even knowing the risk in their society for discrimination and prejudice. And people confuse that decision about living authentically to be a choice, and it's not. Next slide. The other thing we can do is provide gender affirming care. And what that means, it's holistic. It's looking at the social, the psychological, the medical and legal dimensions. It depathologizes being transgender. Historically, medicine has looked at being transgender as a psychopathology, and that is no longer true. It's never been true, but our understanding of it is better. In 2022, the ICD-11 moves the terminology of gender dysphoria, which is in the DSM, and it's the distress that someone feels when their gender identity and their body don't match, or the way that society is treating them doesn't match who they are. That's now gender incongruence, and it's under sexual health, not mental health. Because being transgender is not a mental illness. Being gay is not a mental illness. Though, again, because of that unconscious bias, because of the messages we were sent, often grounded in religiosity, to say that this is bad, this is immoral, this is a sin. None of that is actually grounded in science and evidence. Basically, it doesn't, when we say gender affirming, it doesn't mean trans is good and cis is bad. It just means that the patient's gender identity is what it is. And it's neither good or bad. It's just a element of the human being we're interacting with and trying to take care of. we always want to ask trauma-informed questions. And when I say that term, what I mean is we want to explain to the patient why we're doing what we're doing, why we need the information we're trying to gather, and work in partnership with them so that if the way we have to get the information, we need to do a pelvic exam. You know, a transgender boy, that may be very traumatic to do a pelvic exam. You know, conversely, a transgender girl may not want to be talking to you about having a penis. So it's listening to the patient, explaining what you're doing, giving them the chance to say no. Again, if it's clinically relevant. I'm a trauma nurse. If you come in because you've been at a horrific accident and I'm trying to save your life, I'm not having these conversations with you. I'm going to stabilize you, and then maybe later we can have some of these conversations. But in that moment, I'm not. So you have to, use your common sense and what the clinical presentation is, and avoid this transgender broken arm syndrome. And what that is, when you find out that you're dealing with a transgender patient, you don't immediately become stupid. If I'm dealing with a patient because they broke their arm, I don't say, I can't take care of you because you're transgender because nobody taught me how to do this. If you're trying to deal with a broken arm, you know how to take care of a broken arm. You know you might need an x-ray. You know it needs to be set. You need to check, for neurovascular compromise. You may want to give somebody something for pain. You know how to do this. The other thing that happens is when you find out the patient's transgender, and this is not so much for adolescents, but more for older adults, when you're dealing with adult populations, you focus on what's the status of their genitals, divorced from what their complaint is. Again, if I come in for a broken arm, whether I have a penis or a vagina really has nothing to do with how you're going to fix my broken arm. And if I'm on estrogen, you don't immediately tell me to stop taking estrogen or say that I broke my arm because I'm taking estrogen. I could break my arm because I was in a car accident. But again, it's because the person's transgender, you immediately ascribe it to that.
Dr. Paula,
Yeah.
sorry to interrupt you, but we have more 5 minutes.
Okay. Let me, I will speed up a little bit.
Thank you.
So there are standards of care. Next slide, please. There are standards of care. This isn't experimental. This is not cosmetic. Next slide, please. Care for adolescents is medically necessary. It's age and developmentally appropriate. No one is giving hormones or doing surgery on a prepubescent child. It's grounded in science. And there's no such thing as rapid onset gender dysphoria. There's no evidence for this. That's that social peer pressure, you're seeing all these adolescents all of a sudden describe themselves as transgender because their friend is and it's trendy. That is not supported in the science. Next slide. So usually we're talking about hormones. In the United States, the use of hormones for gender affirmation is what we consider off-label because it hasn't been approved by our FDA, our drug administration. Next slide. There is no one surgery. There are facial surgeries and top surgeries and bottom surgeries. Again, this is something that only we're talking about older adolescents, actually 18 years old or the age of majority in your country. The new standard of care, which just came out, will modify this a little bit. But this is not something that you're talking about for a prepubescent child. And you don't start doing any type of intervention until a child reaches Tanner stage 2. Anyway, next slide. The best thing that you can do is be an advocate for the patient. I would argue that as nurses, our code of ethics requires us to do this. Next slide. There are pamphlets that are available. I looked in the United States to see if these were available in other languages. I couldn't find that, but these are resources you might be able to access and then have locally translated of how to be an ally for adolescents. Next slide. Put put some websites for various resources, and I know unfortunately all of these are based in the United States, but accessible, and again, may be places where you can find some information that might be more applicable. And then lastly, any questions that you've got, anything that you wanted to ask that I was unable to touch on, and I know we're coming up towards the end of our time.
Thank you. Thank you so much. Thank you so much. I think that we have a great, great conference, and it was very good to hear your experience and also to share with us, how we should treat our patients. And it was important to me also to highlight this, though, that as you asked, how they identify themselves, though, instead of to have ourselves, our position or our terminology. And just your final words. Though we have most of our participants, they are nurses. Some of them, they are working with adolescents. Others, they are from at the university level or students. No, what will be your final words that we can leave this webinar with these words to think more about? In a small phrase, what will you give us, as your final word to keep us think about, or to change our practice or the way that we teach tomorrow?
Human beings are diverse, and we as nurses must learn to take care of this wonderful intersectionally challenging, complex body of people, and never forget our basic humanity.
Very, very good. Thank you so much, Dr. Paula Neira. This webinar is recorded, so I'm sure that more than these 324 persons, participants that follow you in this afternoon, many of the nurses will be able to hear your thoughts, your expertise, your knowledge, and how, as nurses, we need to care more adolescents and adolescents transgender, as you said. Thank you so much to our participants. Have a good night. Have a final good afternoon, and we will see each other in the next webinar. Bye bye to all. Thank you. Thank you again.
Bye-bye.